talks, we try to really keep them informal. They are Q&A led. So stop me at any point and point me in another direction. Feel free to ask anything. We answer anything. Because of the time restrictions last night, we didn't really give much of the background or explanation of our practice, so I'll jump into that, even though some of you heard it afterwards. We started AtlasMD fresh out of residency, September 2nd, 2010. That date pays homage to Ayn Rand in Atlas Shrugged, for anybody who's read the book, like everything else we do, and a lot of Randisms throughout our website and development. But going through, when I was starting my intern year, by the time I was graduating, the third years who graduated were quitting medicine. So in 2 or 3 years, they said, my dream career is so awful that I'm going to quit and do anything else. That was the direction I was seeing medicine going. And people ask us all the time, was it hard to go out and do something new like this? No, it really wasn't. I said the scary thing was going to go and do an insurance-based medicine. I saw everyone banging their head against that wall. Anything else seemed like it at least had the potential for being better. I first got my introduction watching concierge medicine in 2000. I was working for a plastic surgeon, Kenny, brilliant cutter, great guy, awful businessman. He made less money as a practicing physician than he did as a resident because he didn't appreciate that you only get paid by billing correctly. It's paperwork. You can be a so-so doctor, but if you're awesome at paperwork, you'll make money. And that really flew in the face of everything I'd been taught. You just be good at what you do, and the reimbursement side would make sense. So watching MD Squared, which was the high-end concierge, the $25,000 per person per year out of Seattle, and then this other doc, Dr. Vern, who was a wonderful mentor to me out of Portland. He did simple care. It was 50, 100, 150 for visits based on simple, medium, or complex. And I watched that until 2010 when we launched, and lots of doctors would come out and try something. And typically it was just very high prices, fed up with the system, I'll wash my hands of it, charge as much as I can, hope I can get 100 patients who are dumb enough to pay me 10 grand a year, and great. And I know that's not a solution to the system, but it might, if I can carve out a niche for me, then I can keep going. It never made sense because that wasn't a model that was applicable to the masses, both as patients and physicians. If we were really going to get to a sensible system, this had to be something that almost any doctor could come out and do for about any population, whether they're rich, poor, healthy, sick, urban, rural. So with that in mind, I joke all the time, I built it after my dad's trash business model. My dad was a trash man for 20 years. He's a lawyer now, so I still tell people he's a trash man. It's a lot less embarrassing. Yep. And so, but it was such a simple business model. It was flat price per house, and we pick up whatever you drag to the curb. There was no need to over-engineer that problem. And we got to healthcare, and it was just completely over-engineered. And I love working hard. I hate filling out paperwork. So we said, one, insurance is a tool, and we're using that tool wrong. You use a shovel as a hammer, you're not going to make it very far. And insurance, by definition, is for major expenses. Even the fact that we say catastrophic health insurance is redundant. All insurance is for catastrophic things. Car, home, life. My wife is outside, I think. I'll make the joke again. I have life insurance because I want my wife and a cabana boy to be very happy someday. But I get a couple $1 million of coverage for a nominal amount each month, but I pay more than a mortgage for my health insurance each month, and I don't get that value. That's how we know we have a broken system. But it's not because insurance is bad. And I'll go so far as to say it's not even their fault. Sure, they've done some not so great things, but it's because we, as doctors, future doctors, have let them, okay? We're the gatekeepers of care, we're the providers of care, we're the source of the innovation. I can't tell my accountant how to design a better model because I don't know that system well enough. And the insurance can't tell us how to run a better clinic because they're insurance people. So when we accept an idea that we should not have business entrepreneurs who are also doctors, we accept the premise that we can't innovate, that we can't think outside the box, that we can't fight for our patients. And I reject that. I say physicians used to have a proud tradition of innovation. And I'll use the surgical model. curved scissors, straight scissors, blunt scissors, any product known to man, any variation on that we can invent to make a better surgical outcome, we do. We have every retractor known to man, and when that doesn't work, we have a malleable retractor. And when that doesn't work, we have med students. So because the insurance isn't part of that bedside world, and we know that benefits our patients, but then we come to the business side of delivering care, and well, that's beneath us. My professors have taught us that, our attendings have taught us that. The idea is I can't be a good clinician that focuses on the money. To which I ask, how are you a good clinician if you don't focus on the money? On some level, if we are going to honor our oath to do no harm, that means no financial harm. That means take a system, take ownership of that, look out for our patients and say, how do I get your migraine medicine cheaper so that you can be employed, so that you can have a better standard of life, so I can do the actual thing I'm supposed to do for you as a physician, which is heal you. And so if the pharmacy, local pay, is going to charge $88 to $256 for Imitrex that I get for $6, then clearly we have a broken system. Pharmacy is not going to reinvent that. They're not going to volunteer a lot of profit to go out the window. We can, though, because we have our patients' interest first and foremost. We're the boots on the ground. So for all those reasons, we said, let's get to a logical system. Family medicine's too messy to charge by time, by diagnosis, by health condition. It creates more problems than I wanted to deal with. All right, what if somebody's really sick and needs 2 copays, or if you a copay per 30 minutes? The funny thing about being sick is you usually have less money when you're sick because you're not working. So making people pay at the time of service and pay more an unpredictable cost. I like Netflix because I know exactly how much I'm going to spend. I don't have a very, you watch too many House of Cards episodes, we're going to upcharge you. Whoa, I thought that was free. Oh, the first 6 are free. But then you binge watched, and so we're going to charge you. That doesn't play, but that's what we do in healthcare. Oh, the higher the code I can give you, and I checked all these other boxes. I talked about your smoking cessation and your family and this and that and the other thing, and I made the government very happy. Yeah, but you didn't fix me. Oh, that's beside the point, because I did all the paperwork. So, back to our model. Simple membership based on age for all the services we could offer. And in that sense, we were just young and hungry, and we wanted to be to take the model as far as we could. And I think a lot of times, it's not that we're so smart. I don't know if Steve Jobs was so smart. I think successful people ask the right question. If you say, what's the best way to build a phone, and you remove all other obstacles, you're going to get to a really good product. If you try to make too many masters happy that are peripheral, though, you're going to get a poor quality product that doesn't serve anybody well. Well, what does the government want, and what does Blue Cross want, and how do I make Aetna happy and meaningful use? Well, then, by the end of it, we have what we have now. But if all I have to do is be smart enough to ask one good question, what is best for the patient? All the other business things fall into line. What's best? Well, no copay is best if I can get to that system, because that means maximal opportunity for healthcare and minimal financial risk. Well, how do I do medicines? Well, the cheapest I can make medicines, the better it is for patients. Great. And labs, and copays, and procedures. Well, what about access? Absolutely. How do you access? How do I access it? When my son fell the day before he left for DC, bit through his lip, I am right there. But I am right there in the pocket of all my patients. Some have texted me from car accidents, little selfies that they cut their face. Great, I'll be there to sew it up. Grandma cut the turkey, cleaning it up. Great, I'll meet you there. So I am no more than a text, a phone call, an email, an image away from my patients. And having that much access for free means they're going to use me as much as possible, which is what I want. And everyone's like, what if they use you too much? Well, you can always set some boundaries, but I can't help you if you're not communicating with me. The more you communicate with me, the better of an outcome I can do, because the more we're talking. You have to say, well, boy, I don't know if that's an infection or not, but I don't have a $25 copay, then your patients are going to self-limit their care. So, membership for unlimited home visits, work visits, office visits, and technology visits. So, because we don't take insurance, we can be more flexible to allow patients to use non-secure communication. And guess what? They don't care. So we have this idea that security is the most important thing. HIPAA, I don't even know if you guys were born when HIPAA started. Oh my God. HIPAA was a 1996 law that was, you guys are born before 96, right? Okay. If I make a 80s movie reference, will you get it though? Flux capacitor? Oh, okay, good. Then there will be an 80s movie reference. So, HIPAA was written in 1996. When I was 15, the Spice Girls were topping the charts. Internet Explorer 3 was released, and the Dow was at 6,000. It is an old, antiquated law, and like most laws, just doesn't move as quick as the industry does. So back in the 90s, when people still used the word hack, everybody was worried about hackers. And right now, we all share everything. So I think it's just part of it was an evolution in how people perceive their data. But they also, they know security is important, but they also know there's a limit to that. Anything can be broken into, big governments, big businesses, Target, Home Depot. What they really want is access, convenient. Pick up my phone at the stoplight, text my doctor, because that's what I'm thinking about it. So not taking insurance allows maximal flexibility for us to meet our patients' needs. And we keep everything secure, but that's beside the point. Then no copays, because again, a copay is designed to get the patient to say, is this really worth 25 of my dollars? And we don't want them restricting their own access to care. But also when we go and sell this to an employer, hey, no copay is better than a plan they've had in a long time. Then any procedure we can do in the office is, again, free of charge, because we can look at that and say that is a fixed cost, that's absorbable, minimal risk for abuse, and it's a high value to the patient. EKG pads are 3.5 cents a piece, and so to do a full 12 lead, I can absorb that cost. And few people are abusing EKGs. They're just not sexy enough to abuse. Toenail removals, I probably have $2 in it. If you're abusing that, we're going to talk about it at your next toenail removal visit. And so those are just easy things, but they're very high value to the patient. And so often define your goal. The goal for me wasn't to make an extra 36 cents each time. The goal for me was to grow the business. The wow factor, the peace of mind, the comfort for a patient to be able to say, whatever I need in this arena is probably going to be cheap or free. That takes out all the worry from healthcare. Everybody constantly worries because they've seen these ridiculous high prices, $1,000 for blood work in the ER. They have no idea what anything will cost. So, and we've done that. That's us, more or less. I mean, other people have done it under our name, but the physicians have let it happen, which is why physicians have such a poor trust rating with our patients. So the ability for me to do all these procedures for free means now they don't have to be an expert in pricing or transparency or second guess anything. I'm not even trying to upbill you. You need an EKG? We'll do one. Why? Because you're already worried about your heart to ask for one. Am I going to be the doctor who says, sure, if you give me $30? Not that that would necessarily be a problem, but it's not the relationship I wanted with our patients. And so we wanted them to say, there's no reason to distrust us. Steve Covey has a great book, The Speed of Trust. And low trust industries are slow, expensive, bureaucratic, cumbersome. High trust industries are fast, efficient, meaningful. And we wanted our patients to know whatever we were doing for them was in their best interest. The funny thing about patients is they don't have to be logical, right? And when you're distrusting someone, you really don't need to be logical. And I would see it in the ER all the time. Oh, absolutely. Yeah.
You keep saying we. Is we like you and a couple other guys are in practice, or can you say we?
I probably use we intermixed. I created the practice, but I'm very fortunate to have several doctors who were behind me from very early on. So Dr. Doug was there from the first few weeks after we opened, but I've been working on the practice for a few years before we opened, and then Dr. Michael came on board. So I say we in the general. We didn't know the exact makeup of it. We knew memberships, we worked towards all these things, but I didn't have wholesale meds ready day one. So a lot of it was, we figured it out along the way. Doug and I looked at each other and said, boy, if we get more equipment, what do we charge for it? And we just kept saying, well, I don't know if we want to charge for it. We got to that point where we said, we know if we had a standard investor relationship, that's why we're self-funded, is the investor would understandably say, at some point we need an ROI on devices that we're buying to upgrade the quality of the clinic. And for us, the ROI was growing patients, recruiting and maintaining patients because of a wide level of services. So the we is just, yeah, me at sometimes, but then the clinic as a group at other times. So that high trust, we wanted the patients to believe what we were doing. I'm not making money off your simvastatin. But they'll think that, well, doctor just prescribes that because he makes money. Well, it's 66 cents a month. So even if I make all the 66 cents, it's not really that much. Uh-huh. We have a very reliable supply chain from Honduras. Yeah. So we actually use the third largest wholesale supplier and a med. They're the third largest in the country, but the largest that works directly with physicians. The other two, like McKesson, they're just big enough. They only work with pharmacies and hospitals for volume. So we can go in and order, look at anything, order it. Most things are shipped overnight to us free of charge. So if I don't have the right Effexor dose in stock, I can get it by tomorrow. And we can always send to a pharmacy. We're neutral in that respect. If a patient wants to get it with us across town at the pharmacy, wherever, we just want them to get a good price. And that's the most important thing to us. And we'll even show them, oh, it's cheaper at the pharmacy than with us.
So for example, big academic centers where I work, they may actually contract with the same person as they're contracting with, because they're the source of
the pharmaceutical supply, yeah.
I got you. So their pharmacy may be getting that from...
Already getting it, and already getting it at that price. Probably a better price. And mark up the hell out of it. Why? Because we can. So we don't have a free market system, really, because there's not competition, not free-flowing information. There is a reason the price is driven down. But when the consumer pays, when insurance pays, it's a third party. My goal isn't to drive it down so Blue Cross is more successful. How much can I squeeze? Partly because I'm mad at Blue Cross. You screwed me on that UTI in the hospital, so I'm going to, and now it just becomes a shell game of, because there's no trust, versus the relationships we built with insurance companies who accept our fees, who lower their premiums and give discounts to our employers because they look at our system and see high trust. And that's what we wanted. Just like the patients, what's good for the patient is good for the employer, is good for the insurance company. There's no opportunity for me to upcharge you. Dr. Doug is a huge car guy. I'm not. So every time I go to Jiffy Lube, they try to tell me I need to replace my flux capacitor. I'm like, geez, that's the third time this year. It seems to go out a lot. Because I don't know enough to know when they're manipulating me. And so every time I go, I'm suspicious of it, even before I get there, even if they do a good job. Because just globally, I worry about that. And Doug wouldn't, because he knows exactly what they're talking about and wouldn't buy something he doesn't need. So, but in healthcare, that's where we need relationship where the patient understands there's no opportunity to nickel and dime you. We often hear it's too good to be true. Concierge medicine for $10 a month. So the patient ends up being a little distrusting. That just seems like it's, I expect good things to cost a lot. And, but unlimited visits, no copays, free procedures, wholesale meds and labs. And I'll be very transparent with anybody we talk to, and even our patients. It's cost plus 10%. So now when the patient knows that, the employer knows that, the insurance company knows that, there's just no fear that I'm going to come in and be like, yep, I'll do text messages, but really only to make you come in and pay another copay. Because all I got to do is bring in X number of people more per month for copays, and then charge that to the insurance company, or charge it to you or the employer. So we wanted such a clear, transparent, applicable system that you could take that and copy that anywhere in the country. Again, meds, 95% off on a lot of things. Even chemotherapy. We don't do a lot of breast cancer chemotherapy in our family practice. Surprise, surprise. But when our patient had breast cancer and went to the oncologist and he said, here's the best medicine for you, go to the pharmacy. She went there and they said, yes, it'll be $600 for a 2-week supply. He said, no, thank you. And called us and we researched it. And sure enough, we get wholesale for $6. We were just as shocked. Yeah, the generic, same things. Oh my God. We gave it to her for free. Just so we could say, AtlasMD now providing chemotherapy. And we really did. We gave it to her for free. We were just as shocked. And so that's why you have to reach out. and innovate. But I really do appreciate, like I said last night, the dichotomy. A good physician is saying, I've got a decade's worth of data to show me I'm doing the right thing. A good entrepreneur is saying, I'm doing what no one else has done before. That's how I'm good. And you know, it really is the third-year med student problem. I've got to find a zebra. I've got to find something that no other doctor has picked up on yet. So you're looking out there. So, in this tangential thought process, we wanted to extend that discount to everything, labs, just by doing client billing with the lab services, then a $1.50 CBC, a $3 cholesterol panel, a $2 A1C. Quest? Yep. Because we pay them direct. Because now Quest doesn't need any documentation, any coding, nothing gets denied. I pay 100% of the time. No hassle, which is not what they're used to. Now, I squeezed them very hard to get good prices, but they'll give them to you eventually because they'd rather make a little money easily than make more money in a difficult way. But surprise, surprise, by the time you see all the paperwork that flies back and forth for a CBC, who cares? Why are we insuring this? It makes no sense whatsoever. Plug. And so when you can do that, you're helping your patient work with the insurance. If we can make insurance 70% cheaper, more people are going to have it, which is what we want. And yes, that wasn't a fault of our model, but they still tell people to have health insurance. Yes, because bad stuff still happens. We make everything that we can make affordable. For some of you, that'll be pediatrics, OB, mental health, surgery, but each one of us, as we push out there, imaging. Just by doing the client billing, we can get an 80% cheaper MRI. Now, you don't need insurance if you can buy your MRI for $400. The insurance can say, okay, if we're covering fewer MRIs, we can lower your premiums because you're managing our risk better. It's all about managing risk.
Can you explain the thought process how you negotiate the imaging again?
Cash.
So I'm the imaging company. We do the dialogue. How do you...
I'll give you $400 if you'll give me an MRI.
Okay. What's the going rate?
Usually they won't go below Medicare rate. Okay. Even though technically there's a loophole to let them, that's the simplest way. So now it's not quite, here's $400. They're comfortable giving us an invoice at the end of the month because we always pay it. And then we decide how to get paid by the patient.
You defined 3 areas you wanted off the lowest cost, medications, labs, and imaging. And then you went out to each of them saying, I'm willing to pay you cash. What's the lowest rate you give me?
Yep.
And so you set that up, and then as they got more trust in you, more higher volume, maybe you could renegotiate that lower. But
Yep.
the point is,
Well, competition. At first, only one would give us cash rates. So it was like $500 for an MRI, which is still a good price. Then eventually, another company moved into town and said, we won't be beat. If you give us your prices, we promise to beat them. Of course, if you give me the test questions, I'll ace the test. I said, no, we'd love to work with you. I don't care who I send my imaging to, because my responsibility is to the patient, not to keeping my rep happy because she brings me M&Ms for my kids or whatever. And so they said, okay. Well, we came back. They guessed at our prices. They were right on some. They were wrong on some. I probably extended how important that was for them if they wanted our business to be competitive. And it's interesting that even though they're the cheapest by far, it's not like we get lower quality. We still have a high quality MRI and a CT. But for that group, the radiologist will call us before the patient's left the building sometimes when it works out though. So great time, speed, quality, but they send their techs home if there's no one who's scheduled for a scan. That's how they keep their prices low. Other places have higher prices but have their tech there all the time. So it's this interesting, they're adjusting their business model to be competitive, so we adapt to that. So now we have a list, and I can tell a patient, do you want it quick, fast, now, cheap, better? Let's have that discussion. And do you want it at the orthopedic center? Because now we get an orthopedic consult for free as part of the MRI. That's a nice plus too. Then we'll expand into DME and pathology and anything else. So skin path dermatopathology, we had $300 per tissue sample when we started, and so we just kept looking for the best price. Now it's $40, and we send it to Boise, Idaho. Cole Diagnostics does an amazing job. So as long as we keep asking what is the best scenario for the patient, the trick is kind of though that I have the time. Not that we care more to do that than other doctors. I'm not trying to say that. But we built a system where we're profitable at 5 patients a day, not at 40 patients a day. So at 40 patients a day, you're just running so ragged, you don't really have time to get out of the hamster wheel and go look for better solutions. So we're very fortunate in that sense that work smart, not hard. Now this reference probably none of you will get. I Love Lucy, conveyor belt scene, chocolates, raise your, okay. You're too young. You get it, okay, yeah, all right. So you can wrap chocolates on a conveyor belt, and just because the belt goes faster doesn't mean you get more quality work done. In the scene, she starts dropping chocolates all over. And that's what patients feel like. They're just being dropped. Oh, I forgot you were even in the waiting room because we had so many people, and it was an hour and a half wait, and we're just sort of running around confused. So it really was the fact that we were more efficient on a lower volume gave us opportunity to say, okay, now that we've run into a new problem for a patient, pathology, how do we fix that? Or physical therapy or speech therapy. So my daughter has Down syndrome, and we had to do the same thing. In residency, we had great insurance. You think, so we had a $45 copay for a 25-minute speech therapy visit, and half of that was spent with her documenting. That wasn't a whole lot of good use of my dollars. Now we pay $35, and I get 45 minutes cash with a speech therapist. She does it out of her home. She keeps all the money. There's no insurance billing. It's actually a better system. And then when we want to in the summer, we increase the speech therapy to twice a week. Why? Because I'm paying for it, so the speech therapist is happy to let me. If I had to run it through insurance, well, I'm spending their money. So of course they're going to say, is that a good use of our money? And that's not wrong of insurance companies by any means. That's what they have to do to keep premiums low. Whoever pays the piper picks the tune. So the more that we can get our patients to use less insurance for their day-to-day stuff, the more that they get to pick the tune and say, what is the best type of care for me? So that was the idea behind the clinic. It's been 4.5 years later. We're full. We have 3 physicians. We do all of our consulting for free because we want to see every physician be successful in this space. We've started some 70 practices in the last 15 months in this model. It's been a lot of fun. It's exciting. For when we started, they said this would never work, and I understand why. I mean, it's a difficult model to appreciate. And now we're seeing 15 to 20% of physicians polled would convert to this model now if they knew how. So now we just got to get the information of how out there. We also do the consulting for free, though, because self-interest. Each doctor who did it and tried and failed created a disproportionately large splash in the direct care world. A couple examples where a resident came out and had his structure wrong and failed, and everyone said, see, maybe it just doesn't work. No, I can do a post-mortem on his practice and know exactly why he failed. Prices were wrong, value was wrong. Didn't offer meds, labs, copays, procedures, didn't work with employers, couldn't fix the insurance thing. So if you don't build a really good clinical model, you can't combine that with a really good insurance model. One of the things that made us so successful is we did. We said, it's not enough to wipe our hands clean of insurance, because again, patients will always need that backup coverage. But how do we make those two things work better? And if the better my clinic answers the customer's needs, there's the less the insurance has to do. So who was I talking with about Freakonomics? Freakonomics, great example of appropriately aligning the incentives. Make sure that everybody is where they should be in this process, and then it'll work better. Right now, the current system, patient pays their copay, puts down their insurance card, and insurance is on the hook for everything else. Well, that means they have to control all of that to keep prices reasonable. In this model, patient pays for memberships, meds, and labs first. Doctors paying for all the services they provide in-house free or at low cost. And I expect that to be a cold war of sorts. Doctors will continually add and innovate and bring things into their office to say, I'm better than the other clinics. Good for patients. Next, the patient pays their copay, deductible, health savings account type scenario. And in an ideal model, then the employer in a self-funded model would pay their deductible per employee. Fifth to pay the insurance company. So if we've managed their risk a whole lot better, then of course they'll lower premiums. Lower premiums mean more people on insurance. We've taken groups of 15 to 50 employees, and they'll file 0 claims against their insurance in their calendar year. That's car insurance, that's life insurance, that's profit. And I know that's bad, everywhere else, not in this group probably. But that means we've added so much value. Now, that doesn't mean they didn't get health care. They got tons of health care through us, but we don't file any claims that the insurance has to pay for. And granted, those are good examples. Every, so many years, you're going to have a bad year. Someone's going to get cancer, have a heart attack, have rheumatoid arthritis, and need, biologics. But that's not everybody. So we do the best that we can for whoever we can. And
when you, so you go to the employer, you present your model, they already have a pre-existing insurance relationship. So after the insurance company sees the benefit of the interaction with you, then the company go back to you and say, hey, listen, you haven't really required your services, you haven't managed our new relationship with Josh has lowered our costs, so can you lower the premium? Is that the kind of...
We typically, when we have a relationship with them, it can go one of two ways. A, they have their insurance and they're not at a time where they're able or willing to change that, but they offer their employees either point them to us and say, hey, that's a really cost-effective way to get health care, FYI, or we're going to pay some portion of it until we change our insurance, so go. But the majority of the time, we're getting our quote for next year, and it's 20 or 30% more. We couldn't afford last year's insurance. So they know that this is what we do. They come in and say, can you lower our insurance premiums? Or if you don't, we're going to have to fire employees. And that's a downward spiral for any company. Insurance premiums. But now we do carve-outs. Carve out medicines that we get for a penny a pill. Carve out co-pays, imaging, a lot of these things. Leave the catastrophic component of that intact. So instead of a $10 copay for medicines, you have a $500 deductible. That makes a huge difference in the insurance company's risk. But if you need insulin, inhaled steroids, something, your exposure is only $500, but you probably saved $1,000 on your insurance for the year. So now it's aligning those incentives. Without us, that just feels like really bad insurance. It doesn't cover anything. My car insurance doesn't cover a lot, but I'm happy with that. I don't want homeowners insurance to be covering lawn care because it would be expensive. So we go in, we show them that we can typically decrease their premiums by 30 to 60%.
So it sounds like you're empowering companies to understand their insurance risk and reimagine their insurance risk. That allows them to go back to the insurance company and speak to them on terms that they appreciate.
Well, we have an arm that helps with the insurance. Independent guys where they're not employees, but they understand our model. And that was the unity, is we needed someone who understood our speak and the insurance speak. So they could say, yeah, we can sell you any insurance plan you want, but we know really well how Atlas works so that we can customize a plan for you to meet your needs. If the employer wants more co-pays or wants to pad it a little bit, great. But self-funded is the example we're using. And are you guys familiar with self-funded insurance policies? I'm probably not the best person in the room to talk about them, but it's like an HSA for the employer. There's a certain chunk of money that can go back to the employer if it's not spent. And in a typical model, that means the employer is going to say, well, go to this lab, or this pharmacy, or this doc, or don't go to the ER, go to urgent care, and just educate the employees on most cost-effective techniques. Now, we've shopped all that for them. So we can say, look, we're the cheapest for labs. We're the cheapest for meds and procedures and all this stuff. So that your employee doesn't go to the ER at 5:30 on Friday for a bladder infection because the doctor turned his phone off, because he doesn't care. 5:30, I'm not paid to treat you over the phone after hours. In fact, I'm disincentivized to give you free care, because if you find out I can give out free care after hours, why come to the office and pay for it? And so then a patient goes to the ER for a $1,000 bill for something I can do over the phone for free or cheap. That's protecting the patient's money, protects the employer's money, protects the insurance company's money. So at some point, those are all the things that have to happen. So as the employees start to understand that their dollars can come back to them if that's not spent. So we had a group, Total Printing Solutions in Wichita. 17 employees. 2013, they spent $98,000 for their insurance. By the end of 2014, they spent $48,000. Yeah, they had a risk pool of $19,500. They got $19,300 of it back. So for one office visit, that was outside of our practice. Now they all got care, but our stuff doesn't show up on the insurance side. So we've managed that risk better. That is a model where this is the the Napoleon in me is going to come out. World domination. That changes everything. Okay, I mean it changes family medicine. It changes employers. It changes insurance. If we could decrease the cost of insurance premiums by 30% for employers across the country, we'd have an economic boom the likes that Reagan would be jealous of. If we lower it any more, that's even better. If patients can get, if we can break the hold that Target, CVS, Caremark, Walmart have on medications, and every doctor is now dispensing wholesale meds, fantastic. Better patient compliance, cheaper meds, better results, long-term decrease in chronic care, all kinds of things. More doctors stay in medicine, more med students go into primary care, outpatient settings, everything gets cheaper and better. So it's sunshines and rainbows and unicorns from here, as far as the eye can see.
Do you see any kind of model like this working in like an emergency room?
Actually, yes, I think it could work for that. Maybe a slightly different model. What I love about this is there's a Kia and a Mercedes and everything in between. So you have Uber, and you have Zipcar, and you have Hulu, and you have Netflix, and you have Amazon Prime. Everybody does something in the same space, but just a little bit different, and that's fun. So you could have an ER that's just freestanding in cash only, but because we don't take insurance, we don't have to do EMTALA and all the craziness that adds to the expense, then we don't have to pass that expense on to the next consumer who's paying. Then you could have, I think, hospitals, this is where I'd see it almost actually like a co-op or an insurance company saying, we already do senior care. Well, if you're a senior member, a senior friend, you get a better room in the hospital, or you get in quicker, or these little perks. What if for $10 a month, I just got a big savings at the hospital? $10 a month is nothing, and boy, I might have to go to the hospital. So if you had a community of 100,000, each paying $10, $15 a month for better care at the hospital, now the hospital is selling access to care instead of trying to pay for care that they've already done. There's a bunch of different ways maybe to work that if we innovate and think outside the box. Maybe a bunch of doctors get together and manage in urgent care between them. So we have an on-staff nurse for IV fluids or Toradol for migraines, just after-hours care. Maybe not trauma care, but that's really what insurance is for. Trauma care is exactly what insurance is for. I can't predict when I'm going to have a car accident. That's expensive care. It's high-end. It has to be quick. You don't know where you'll be. So that's one option where I think it's just perfect for insurance type. Mm-hmm.
Do you recommend an MBA?
No, I don't recommend it, but it's not that I'm against it. We have in Kansas City, there's a med school that gets a dual DO MBA degree, or at least they have that option. We have a lot of those students come through. They do tend to be definitely more educated on the process of it, the accounting, the taxes, administration. I didn't know any of that. It's nice to know those things, but you can hire those things too. I think more important is that ability to problem solve, innovate, think outside the box. There's a lot of skills that you can pay for. Cardiology, I'm not doing your heart cath. I can try if you want. And I don't do my own taxes because I can pay for that. So again, nothing against an MBA at all, but at the end of the day, you're probably still going to focus as much on the patient side of it and have an accounting firm, a legal firm, administrative help. Yeah, if that's what your goal, if your goal is to help manage a bunch of doctors, and Lord knows we need that, that's fine too. A franchise or a quasi-franchise type model or branch locations, because at the end of the day, doctors don't think like suits, and suits don't think like doctors, and doctors don't trust suits. So you have to be that unique personality that blends both worlds and says, I'm practicing medicine. I get all of your hopes, dreams, worries, concerns, You can't tell me to prescribe more antibiotics and then tell me to practice safe medicine and keep patients happy. Some of these things are contradictory, and we're so used to being under the thumb of administration who says, well, make people happy but do really good medicine. Sometimes those are the opposite. Some people are mad because they got good medicine. They didn't get what they wanted. And so to physicians, if they're going to work under an administrator, they do appreciate that they're active. But one reason, as much as we love all the other things we do, I don't think I'd ever stop practicing medicine, because then I think I'd lose all the clinical trust and respect I have with practicing physicians. Yes?
The whole difference between the wholesale price and pharmacy price is spectacular to me. I guess I'm just wondering what kind of barriers there are in place within every single physician in the country that works in an outpatient setting to do this and put CVS out of business.
44 states allow physicians to do this. So,
Is it just knowledge? People just don't know about it?
people didn't know. Even pharmacists would tell us, you can't do that. Yeah, we can. And so the Kansas Association of the Medically Underserved, CAMU, they came to us and they were interested in the model and how we're saving prices. And so I was talking to them, how do you do meds? And like, well, we have a paid staff and they fill out the forms, and that's increasingly problematic to get samples. And like, well, how much work would it be to get 1,000 Lasix? Hours, yeah, of paperwork and checks and calls. Well, it's $8. I mean, not to put someone out of business, but just buy it. Even if you give it away to the underserved, it's cheaper than paying somebody $8 an hour for 2 hours to try to hunt it down for free. She said, but we were told we can't. Okay, who told you that? Well, the Board of Pharmacy. Okay, well, in Kansas, the Board of Pharmacy manages pharmacists. The Board of Healing Arts manages physicians and physician dispensing. Some states, the Board of Pharmacy manages both, but 44 states essentially allow this. A few states have some restrictions on that, so maybe 42 actually openly do it like Kansas, but we're working on some of those other states. Montana, Utah, Texas, Arkansas, and the Soviet Republic of New York and Massachusetts. And so a perfect example of questions, regulation, is it improving or hindering healthcare? So of course the pharmacists are good people, and I'm not saying anything negative about them, but they're protecting their turf war, their piece of it. Turf wars just mean the patient loses. And they said, well, but in Texas, years ago, other doctors, they did some stuff that we didn't like, and we don't think that's right. Okay, well, punish those doctors. Don't punish all patients. But you were abusing, this is the funny part, you were upcharging for workman's comp and just charging outrageous rates. Well, then we're target. You're just mad that we're doing your job. You're not mad at what the price is. You're just mad that we're taking business from. And in Texas, actually, a doc can dispense meds if there's not a pharmacist within 50 miles. Okay, so it's not a skill question, it's a location question. All right. I'm already licensed to prescribe the medicine, but counting it, yes. That's the tricky part. You're going to need a Pharm Tech 1-year degree for that, yes. And the funny thing, we don't even count them. I pour it in a machine and it counts them. Why? Because counting it by hand is a pain in the ass. And very inefficient and inaccurate. So, and storage, well, they're all stored at room temperature. Vaccines and stuff have a fridge, but we have a fridge for that. Just like they do. And docs have always done this. They've always had vaccines in their fridge. And Toradol, and maybe some Zofran, some injectable stuff, just for lidocaine, for in-office type things, acute stuff, more administering than dispensing long-term. So that mechanism's already been in place. That's the really frustrating part. Same with labs. When I first saw this, I was with a pediatrician on rotation. I was watching her fill out the paper requisition, and she checked bill to insurance. Right below that says bill to physician. What's that? I don't know. Why not? I never checked the box. Okay, so I just call up the lab after that rotation and say, what's this mean? It's like, oh, we'll give you discounts if we can just bill you direct. Really? How big of a discount? Quest played the whole used car salesman thing. Well, how much volume will you have? I don't know. I don't have any patients. Yeah, but how many do you think you'll have? I don't know. I don't have any patients. I'm not going to tell you that I'll have X amount of volume and then have you come back to be mad. So after haggling with them for a while, we went back to the local lab, and they said, yeah, here's the book. Sign here, put your credit card, your tax ID number, and get out of the way for the next person. It was just that easy. Like, oh, geez, 95% discount on the most commonly ordered family medicine things. a 90 to 95% on tier 2, and a 70 to 90% on everything else. They just printed off their Excel list of all the things that they can order, the code, the name, the thing, the price, the retail price. Because in most states, you don't even need a prescription to get labs. You can go in and have them done. You just may not know how to interpret them. So they had a cash price for us to compare to, $60 for a CBC. Seems high. Ours is too. And so that was almost painfully easy. And that's the sad part in this. And one of the reasons we do the consulting for free is because we didn't actually invent anything. All the pieces were there. We just didn't put the puzzle together. So if every state did that, you would absolutely change Walmart's business model.
So do you think like the competitive market that you're talking about when you're contracting out with that sites like tests and CDC, etc., do you think in like a major city where there's so many, I would imagine there would be a lot more cheaper, right?
Absolutely. Lee, Dr. Gross can speak to that. He has much better prices for MRIs in Florida than I do because there's just more competition. So I'm jealous. Yes and no. One, the hospital is usually suffering in that scenario anyway, so a chance to get $500 cash is still maybe enticing. Maybe a little bit more expensive, but so is milk, but then cost of living is a little bit less. So then the other thing is patients will drive 2 hours to save $500. I know, I've seen it. they'll do that. So I'll do that with a lot of doctors I start in the surrounding area for Wichita. Geez, I called our hospital, they won't give me a rate. Okay, well, here's my rates. It's not a trade secret, and the imaging centers are happy with these cash prices, and they'd like more of them, so there's nothing wrong with me sharing the fact that I have these discounts with other providers. And it's not even collusion because we're all talking about how to lower prices. This isn't like, hey, if we all just keep raising our prices incrementally, well, that's not kosher. So yeah, competition's an interesting thing. But to speak to that point in a broader sense, doctors always say, oh, this would be harder in urban areas. If you're urban, the rural doc has it easier. If you're rural, the urban doc has it easier. We had a doc graduate from residency in Missouri, went to Neosha, a town of 12,000 people. He started with 0 patients in the middle of July, and by the middle of September was profitable at 147 patients. It's 12,000 people. You go post a sign up at the coffee shop and everybody knows by the end of the day. So there is no advertising budget. His rent is a fraction of what my rent is. Profit, everyone asks how many patients you need to be profitable. Well, that depends on what you charge and what your overhead is. My overhead was very high because we felt we had to have a very mature looking established practice, and that was expensive. Other practices now can point to this growing trend of a movement and say, well, this is what I'm doing, and they have that transferable trust, and they have our examples, and we've worked out where to get meds and labs and all these things. So they can start so much farther ahead. We just launched a doctor March 2nd. She had 210 patients pre-enroll from her old clinic. First week she had 60 more enroll. She's up to 325 already. So she is essentially profitable within the first month. Same prices. She stuck to our model exactly, except for procedures. For kids, and then 50, 75, or 100 for adults, 50 for the corporate discount. But she charged a $10 procedure fee. And as much as I don't like charging for procedures, at least it's flat, it's predictable, and it's set. So then I think, yes, it's $10, but the trust relationship with the employer-patient insurance hasn't changed that much. It's a nominal fee, it's clean, it's predictable, and it's not even for all procedures. It was mostly sutures, biopsies, some stuff. Where we're willing to absorb $2, $3, she wanted to make a little. Great, but she's also a female. She's a she, yeah, and I'm not. And she knew that there's not a lot of female doctors doing this yet, and especially no one in her area, and she had a very loyal following. So she said, well, this is a nice little area where I can maybe pad that profit just a little bit. And great, she knew her worth, and she was spot on. She was probably actually low because she grew so fast. Lee doesn't take patients under 4, I believe. I think he does. He just doesn't take Medicaid payment. The big thing is, to generalize both of our practices in that sense, vaccines are expensive. So the two problems are they're expensive and I have to order them in bulk. With my 600 patients, I don't have enough newborns to use 50 MMRs that I have to buy all at once at like $5,000. And then I have that $5,000 sitting in my fridge waiting for the lights to go out, and then I lose whatever's left. That's a risk to me that's hard to absorb. Now, if you're a direct care pediatrician, probably not much of a problem. The other trick is getting insurance to pay for that. We're not insurance providers, and patients aren't going to pay that. That's a high cash upfront cost to a lot of patients. $2,000 for the first 2 years, and you say, well, come with $600 because today's a big vaccine day. And don't worry, we hope that you'll get that money back, but we need to cash. So the difficult spot that we're in is twofold. If you have insurance, it's already free anywhere else you go, essentially for newborns. If you don't have insurance, health department's cheaper by a mile. So even if I could get them and I could figure out a payment system and I could order individually, I still may not be the best provider. So it's not that we don't. Obviously, we recommend vaccines. In fact, we don't let patients who aren't vaccinated into the clinic. But it's not the best product for the patient.
So is the solution for you guys with that is to send them to the health department, or do you recommend that if they're expecting a child that they get a more comprehensive, like, wraparound plan to cover those vaccines?
Well, if they're going to have a child, we definitely recommend an insurance policy. Yes, twofold. If you have insurance, use your insurance benefit to get those vaccines at the best price. If you don't, go to the health department to get them at the best price. Now, there is a solution that I'm optimistic will change, VaxCare, vaxcare.com. And they would be essentially my perfect wave a magic wand solution. They would operate essentially a pharmacy in your office, but just for vaccines. They manage the inventory, the insurance billing. They'll send you one or two. They know what your inventory is. So they'll take it back before it expires to send it somewhere else. Manage that whole process, but they only take insurance. And they're afraid that by working with direct care, that'll upset their insurance contracts. So they're a little hesitant because their profit margins are thin because it's vaccines, to upset the balance. We keep telling them that won't be a problem. So as we reach critical mass, I think at some point we can convince them or a similar company to answer that problem for all of us. But some states, no one pays for vaccines. State pays for all of them, and you just go to the health department.
Do you have to meet any kind of volume for your wholesale discount?
Nope. The more we order, the bigger of a discount we get. But we do have a GPO for practicing doctors like this, so the more of us doing it, the better the discount we all get.
Can you say a little bit more about the business side of it in terms of, I guess I'm just sitting over here trying to think about, from a financial standpoint, what could cause you to fail?
Oh, sure.
And the only thing I can come up with is number of patients.
Mm-hmm.
Because you've got your overhead, and you've got like some costs of, materials and things to do stitches or whatever.
Right.
But if you're getting your 10% on,
That's the lab.
yeah, it's like there's not risk there.
No, because that's a pass-through.
I'm trying to think, how could you fail financially?
I think, we'll first speak to the finances of it. The base math that we like to use for providers is an average of $50 per patient per month in revenue, not counting meds and labs, because that really is just a pass-through. So membership-based profit revenue. Per head times 600 heads, that's $30,000 a month or $360,000 a year. And we reverse engineered our way to that 50 just using this math. Estimated overhead was around 120, and we actually are a little bit more efficient than that with economies of scale. With 3 doctors, we're closer to about a 95 to 100,000 per year in overhead costs. So, but the 120, 360 minus 120 gets you at 240. So it's a primary care doc making 240 a year, seeing 5 patients a day. In the office, I'll do text messages and emails and phone calls, and Wednesday I saw 8. It was a busy day. It was like a residency all over again. But I had it coming because Tuesday I only saw 2. So you got to pay the piper at some point. But so when you say that, that sounds a little bit too good to be true for a lot of docs. And how can you make money on that? And so we wanted the model, not that we want to be greedy by any sense, but we want to reimburse the doctors fairly for what they do to keep them in and to attract them from the specialties. So that 240 mark is very reasonable, and I feel that's with our kids at $10 a month, and that's with our corporate discount at $50 for all adult ages. If we didn't have that corporate discount and we had the same number of patients, we'd be making a lot more averaged out. Or if you're just internist and you didn't have kids pulling your average numbers down. So the finances of the business are very manageable. And I don't even think the overhead would necessarily be 120. We often say our overhead scenario is worst case. We built new, we bought new, we went high end on things because, you know, we're a young doc. We had to prove something that we looked legit. And we pay our nurses very well. Our rent's about $5,000 a month, and we pay our nurses about $60,000 a year. We have one full-time nurse, one part-time nurse. So our full-time equivalent is half a staff per physician, which is incredibly low.
Do you think that as concierge-style medicine becomes more popular and competition increases, your ability to keep those salaries high will go down and people will start getting paid less? And then if medical school costs don't go down, then it'll be harder to draw people into that sort of style?
Okay. Good question. So tying these two questions together, knowing that the numbers are at least that good and that there's room for flex. I do the consulting and the traveling and the software and all this other stuff, and I still see my 600 patients very easily. We put it at that number because at the time that the concierge doctor was 400 to 600 patients. It's not a number, a hard number. I mean, also we just pulled that out of the air. The end result has to be affordable, accessible, quality care. So if you're a restaurant and you have 100 tables and you can only actually cook food for 10 in a meaningful way, well then you're going to upset a lot of customers who are going to walk away. So it's really matching your efficiency with the number of patients and the average age and complexity. You know, 400 Medicare patients at $100 would be more profitable than 600 at $50. Or you may have 800 employees and young, healthy, otherwise manageable families. So I think there's plenty of efficiency for a doctor to flex up to 800 patients. At that price, that's another $120,000 in revenue on top. So what would cause us to fail? Low quality, I think, would be the biggest thing. Because we manage the cost in a fairly predictable way. If my amitriptyline price goes up, my patient's amitriptyline price goes up. So it's not unpredictable for me in that sense of, oh no, now I'm eating the cost of something. But that's because we had to design the model right. Some docs would say, I'm going to include meds and labs in to the price of your membership, just because that's easier and you just wrap it all up. Well, that's kind of what we did with procedures, but procedures are limited. Meds are on every month. And Wellbutrin's $1 a pill with our discount. Zoloft is less than $2 a month. Which one am I going to force you to? Let's do the Zoloft here. If it's my money, well then now I'm an insurance company. You know, I've got a formulary and I'm convincing my patients to do the best thing for me, not the best thing for them. It's here's your money and my costs. You figure out the best medicine for you. But it's not an unpredictable expense to me. So that buffers us from something that could cause us to fail financially. So as long as we keep that quality, accessibility, function high, we should be pretty good. To speak to the competition, yes, we could see more patients and make more money, but then another doc might charge less. I don't think it's going to be a race to the bottom, but it will challenge doctors to do that Cold War that I mentioned. There's Constellation. It's not out yet, but it's an app for skin tracking. Take your phone, scan their back. It has an algorithm to track, zoom, grade, monitor. Well, that's a lot better than my, really good. Yeah, and I don't remember this from last year, but yeah, it looks the same. So that, you know, huge, great, free, objective value. I add that in. It doesn't cost me anything to use my phone and take a picture. Now I do that on every patient. Insurance employers win because I'm catching things sooner. I have more objective data that's obtained easier. Patients have a higher value. I can keep my price where it's at. Or, as we talked with some people, are you guys familiar with the app Pact? All right, Pact, you signed a Pact. I can be rewarded for exercising. They'll pay me money if I meet my goals, and if I don't, I pay them. So it's $5 a day if I don't exercise. I get like $1 a day if I do. So it's understandably a small carrot and a big stick, but sometimes that's enough to get people to move over. So what if I offered patients a discount? Healthier patients are easier to manage, and it's not just profit, but if my employers are happy, they stay with me. If the insurance company is happy, they stay with me. So I may not make more, I may just have a better grip on who I have. But if I can tell my patients, here's a discount, if you take 10 blood pressures a month, because our system will integrate their Apple Watch, their Fitbit, their wireless scale, their blood pressure cuff, and that just sinks into my chart. You get 10 in a month, maybe a day apart, and you get a 5% discount. And do the same thing if you check your weight every day, and if you wear a Fitbit and you log 8,000 steps a day on average, another 5%. For long, yeah, I'm making less, but I'm never going to see you because you're healthy, which is kind of the point. And then now I'm efficient enough to see, not see you, be healthy is the point. But now you're healthier, I'm more efficient, I can see another 700 patients and close the gap. That's where I think the innovation will come. And then,
Okay. So I chatted with an older physician who told me that he couldn't have established his concierge business model without having practiced for like 20 years to establish a reputation. So other than buying nice furniture, what did you have to do?
I didn't have a self-defeating attitude. Everyone who's not doing it says it can't be done. So there's just a lot of fear and trepidation about doing a model. Years ago, when there was a board, a National Society of Concierge or Direct Care Docs, and half the board said a doc should never come out of residency and do this, and the other half said, yeah, do that. Why would I come out and build a practice for the 3 years that I hate, and then my patients are going to hate me by the end of it because I'm not doing great quality care because I'm in the hamster wheel, and then say, hey, now come with me over here. Worst case scenario, I start with no patients, go 3 years, and I either quit medicine like my colleagues did, or I go bankrupt, or I'm successful. I was going to hit two of those endpoints either way. So again, if you're rural, the urban doc has it easy, or vice versa. If you're old, the young doc has it easy. If you're young, the old doc has it easy because he has a practice he can convert. If he's been doing it that long, he's been doing good care, and often the ones we talk to are the ones who aren't financially successful, but they've really built a bond with their patients. See 20 a day instead of 40, but they spend a lot of time with each one. So when they change, the patients come with it. I mentioned the doctor we converted. So it's just a mentality. We had no baggage, so we could start fresh. That's a benefit that we have. An older doctor has some baggage that they're going to have to handle, but they know exactly who to market to. Their 3,000 patients who already know and love the service that they're offering. So it's less that one way is better than another, and say, what is my scenario? We talked yesterday that you have a network with the Indian community that I'll never have. I'll just never understand that culture the same way that you do. And so he can build a competitive model that I could never really enter. And each one of us has a rich mix of sports medicine, mental health, procedures, ER, OB, things that we do really well that other docs don't. So competition-wise, it's not apples to apples. But you have to appreciate that with the skill set you have and then just maximize that. Whether you're an old doc with an existing practice, a young doc with no practice. So what we did, the best marketing strategy for us was a good business model. A business model that sells itself is the best thing. It was print ads, nobody reads. Radio was very successful for us because we could tell a story. I talk a lot about the TED conference, Start With Why. People buy why you're doing something, not what you're doing. The example they use is Apple computers. More people have an emotional relationship with Apple than we do with Dell. Because Dell just says, hey, I sell great computers. Maybe they do, I don't know. And Apple says, we want to make your life better with these products. So we tell our patients we want to make our lives better. We sell that. As long as you're focusing on that, I think the particulars of your scenario average out. There's a question in the back, and then we'll jump back to Gail. And
Okay, so I know we talked about this a little bit last night, but there's a huge population in a lot of rural areas of the country that has issues getting access to care just because there isn't a place around them. And you mentioned that people would drive 2 hours to get a cheaper price of, say, $500. Well, these people can't even drive anywhere to do that. And you mentioned that idealistically, you want to make people healthier by providing incentives, getting them to take check their weight, make sure that they're being healthy and exercising. and ultimately make them healthier, see a new set of patients. I don't disagree with that, I think it's great, but that's gonna take a really long time, and these people need care now, and with only seeing, however many, 5 on average patients a day, how do you expand this type of business model to the people that need it the most? Because there's a huge issue with affordability of healthcare, which your model seems to fix a lot, but there's also a huge issue with access, which it doesn't seem to address as much.
Actually, I would say it does, but that's a common question. And so, one, rule is rule. They're always going to have less access. They're kind of used to that. Who's from Wyoming? Great. How far is it between towns? Like 90 miles, he said. Yeah. What? 30 miles to Walmart. So even if you get to your doctor, you got to drive to get the medicine, unless your doc mails the medicine. So distance is distance. There's some of that you just say, well, look, we're not trying to fix everything. Some of those are static that we can't change. You get more of something by making it profitable, by rewarding that. If you can reward a doctor by going out to a rural community, look, I could sign up the 900 people in my hometown and make more than I would make in Wichita because I get all of the patients, plus the farmers who live outside the town, and my cost of living is a fraction of what it is in the town. So there's actually, and then most towns will pay doctors to come out, they'll forgive loans. You incentivize people to come to rural areas. If you want it, you pay for it. That being said, it could be cheaper in a small town because now I have 900 people. I just charge 30 for everybody, and then the city's paying off my loans, whatever. You can incentivize those docs to go to those rural areas. So the question, we see 5 people a day. Well, we're managing 600. That's the difference. But instead of partially managing 3,000, and I can't manage 3,000 real well. When I did the ER, I had a doc, great doc, like him. His model, though, he has 4 mid-levels, more than he can handle. So every night I would see 7, 8, 9 of his patients who just said, yep, go to the ER. I don't have 9 patients in my practice of 3 docs who go to the ER in a year. But different, look at our math, though. He's got 2,000 patients per mid-level plus his 3,000. They just can't handle it. And after hours, they're not paid to take care for them, so they send them all for the easy stuff that we would manage our patients and keep them out of the ER. So it's more important to be efficient than have volume of those patients. And I think that's where we need to get to is it's not wrong that we take care of 600. It's wrong that other doctors are trying to take care of 3,000 and not doing a good job with it. So physician shortage. Oh my God, we don't have enough doctors. And I'll disagree with that. We have plenty of doctors. We have an efficiency problem. There was a study that the AFP quotes, 22% of a doctor's time is spent doing non-clinical paperwork. Who only spends 22% of their time? Yeah. Who spends only 22% of their time? Yes, Bullarky. But this number plays in our favor for being low. They took that 22%, they multiplied it across the physician workforce, and that would be the equivalent of getting 168,000 full-time physicians back in the workforce. Well, they're only saying it's a shortage of 50 to 135,000 providers by 2025. Well, then we don't have a shortage. We just choked a horse with regulation that now our doctors are spending more time on paperwork than patient care. How can we get more patient care? She cuts paperwork. So if we changed the system none, but just got back more time, we could care for all the patients. So I really do believe that there's some docs will see 800, maybe 1,000. Pediatrician might have 1,200, depending where they set their pricing and what their goal income is. But there's enough doctors to take care of those patients and mid-levels and providers. Or if there's not, regulation's not going to change that. The only way you'll get more providers is make it good to be a provider. It's not good to be a provider. We talked to more docs who are about ready to leave medicine. Talked to one from California, said she has the application to go to cooking school, chef school, on her desk. She said, it's that or get out. And a lot of doctors come to us in those kind of dire straits. So there is enough doctors to care for the patients, improve the model, improve the lifestyle, the ability. The nice thing about going rural is I don't have to advertise. Just like the Dr. Joseph Shepard I mentioned, he's filled up with no real extra effort, and he's in a small town and he loves it. So I think we can meet those needs.
Can you talk a little bit more about the software and how you keep track of your patients' histories and information?
So, like most things out of necessity, I guess that's my cue to hurry up. We had 9 different software platforms open in the beginning. Pharmacy software, billing software, faxing, scheduling, email, texting, shipping, and none of them talked to each other. So we're incredibly inefficient. At 200 patients, 6 months into it, give or take, we said, boy, if we brought in another doctor, I'd have to show them 9 different passwords. And, oh, you dispensed that, so that's in that software, but it actually only ran on Internet Explorer. Who uses Internet Explorer? So you have to have that window open, and or you fax it to a pharmacy. Well, that's in Practice Fusion, and if I'm 100 yards from the office, I don't have any of my except maybe the text messages, but then I didn't want to put their information in my phone in case I lost my phone, so you just had to scroll up until you found who this was, and then presume. So we just, out of necessity, started building a piece, slow at 1 developer for the first 2 years, and then we've rolled that up, and we have now 10 full-time developers. And we built it like you would build it if you weren't building insurance. Very logical, again, ask the right question. We track their text messages, their phone calls, their emails, their Twitter, all drops into their chart. The inventory management, if I dispense meds, if that shows up in their chart, pulls from the inventory, adds to the invoice. Same with labs, results, office notes. We said, boy, I want your Fitbit data. I want your blood pressure cuff data. So we had the programmers build that interface too. So now my patients can sync all of their patient gathered health information with our chart. And that just makes me more efficient. And just this morning, patients are texting me, and I have it. It's mobile. It works on all devices. So we built the EMR that we wanted because I worked on so many that were just god-awful. So really enjoyed it. Mm-hmm.
I know your model only has 600 people and 600 patients, but what's your utilization like? I know it's a small sample, but like monthly, year. I mean, I'm sure your yearly utilization, everybody, 100% of them, you touch in some way, whether it's electronic or direct. But like, what's your monthly utilization numbers like?
Probably 7 patient contacts a year, and not just a contact like each text message back and forth, but questions, conversations. Some are in the office, some are by phone call. Some are by text message or email. Some a lot more, some a lot less. Doug had a gentleman, a lawyer, and otherwise, despite that, still a nice guy, and just a very low utilizer until he was in Vegas and had about a benign positional vertigo and couldn't get off the bed. Doug's been to Vegas. He said, all right, where are you at? Okay, there's a Walgreens over there. I'll call out the medicine. They deliver to the hotel, so you'll have your med. He just woke up, oh, this is awful, laid back down, called his doctor, and everything else was taken care of. It is awesome. And everybody should have that, not just a lawyer, but even our low SES patients have that kind of access. I have a woman who comes from the free clinic, and the free clinic's not free, it has a sliding scale. Well, her copay is $45. They charge her $150 for lidocaine injections for trigger points for her fibro. I'm not a big fibro guy. I'm definitely not a big trigger point guy. But if that's what she wants, for 30 cents in lidocaine for me, yeah, it's free. So her 45 copay, her $50 a month membership, cancels out. Every time she has the procedure, she's making money or has a better quality of life. And then all the medicines and labs she gets through us at a fraction of the price and more predictable, because of course the free clinic's just dependent on samples and donations and such. So now she's getting top quality care and actually making money in the process, and it has better quality of life. So